Assalamualaikum
Halo,
Pak Dekan.
morning.
Morning.
Good morning, Dr. Moki Sensei.
ございます。
Hello,
ここに
thank you so much.
つながりました。
Assalamualaikum Prof.
Salam dia.
Iya Prof, iya.
Nanti kita baku atur dengan Dr. Rina sayang ya.
Iya ya Prof, iya.
Kasih.
Ya.
みんな英語ペラペラです。みんな英語ペラペラです。はい。はいはい。問題は、これを先生。もうミーティングが始まっております。
Ya. Assalamualaikum.
Salam.
Waalaikumsalam.
Covid.
Salam.
Prof, kita mulai setelah ada Ibu Rektor
Ya,
dengan Pak Gub.
ya,
Mereka belum hadir.
ya. Nanti saya kontak sekarang Pak Suharman.
Ya.
Sekarang sudah ada 66 ya. Kita masuk dulu sekitar 100 baru kita mulai.
Ya.
Nanti
Ya,
kita
Prof.
sampaikan nih dulu pembicara di.
Ya, Prof. Pembicara dari Jepang apa sudah hadir atau belum ya?
Ada, sudah ada Moki Sensei saya itu. Sudah ada satu.
大毛先生かな。
Ya.
Kita sampaikan saja. Sudah
Ya.
ada juga Profesor
Is
Hiroki.
it, Dr. Mafumi, is it you? Dr. Okimoto, is it you?
Yes, yes.
Oh, okay. Good morning.
Meet you.
Nice to meet you. Ohayo gozaimasu.
おはようございます。
We are still waiting for the rector and also the governor, and then we start. I'm checking the Sensei Shime and Sensei Hiroki.
I'm here.
Oh, you're here. Hi, Professor Hiroki. How are you?
Fine, thank you. How are you?
Yeah, good.
Good.
設定が多分同じものになってるはずなんだ。いや、しめ先生と
Sudah ada juga Profesor Hiro Takafuta.
Oh, okay. Yeah. Prof. Syafri, Prof. Mansur, sudah ada ya Prof ya?
Adik-adik, ya.
Ya, makasih Prof.
Sudah ada Prof. Mansur. Sudah ada. Ya.
Tadi tamunya Prof. Budu sudah di servis.
Oh iya, Prof.
Di Prancis.
Saya ada sempat ke sana. Oh iya, Prof. Alhamdulillah. Terima kasih, Prof.
Setelah dapat treatment tambahan,
Iya,
karena Sonya yang dari Prancis itu
iya.
terkilir di tangga dan ternyata ada fraktur di tangannya.
はい、でも
Kapan terkilirnya, Bro? Tadi?
Malam di
Oh,
hotel,
malam. Oh, kasihan.
tapi di konservatif saja sama rehab medik sama dokter Nila. Karena ya ruas kedua dari
Oh, alhamdulillah. Iya, Prof.
変の共有
Dokter Rina kayaknya Pak Gub sudah ada.
Oh
Pak
iya.
Gubernur sudah ada. Nanti saya telepon dulu dokter ya. Ya.
Rektor.
まだウェイティングなので、
多分スライドショー終了。
そしたらこれミュートになってないか入って
私は入ってます、多分。
Tapi saya ada nih Pak Gub standby juga kalau Ibu sudah bisa masuk.
ほとんどの声を聞こえできる。なんか一個だけ、どの部分
Oh iya, ya oke.
ですよね。
Oh,
これ
di
が
rumah
一
nih
番
nanti
いい
tidak
と
apa-apa saya telepon di beliau di selesai di perawatan. Oke. Terima kasih. Iya.
どうしよう。
どこ行くもんから言おうかトライさせてくれる。
そうそうそう。
Sudah mau mulai Bu, sudah ada Pak Gub, sudah masuk Pak Gub. Kan ditunggu saja.
Hello,
Sumimasen.
may I speak?
Yeah, Mafumi Okimoto Sensei.
Yes.
Sumimasen. Is there any problem?
Hello, this is Toshi Takafuta from Funai Citizens Hospital.
Yes.
Yeah,
Can you hear
Sensei,
me?
is there any problem?
I'm sorry.
May we help you, Sensei? Is there any problem with your Zoom
actually,
application?
I think that our presentation should be the first, right?
Oh iya.
Yeah.
Oh, okay.
And we want to try to show our slides on the screen.
So Sensei, first we have a opening speech from our governor and also from our rectors. So after that we will begin the presentation. So we have a opening speech first, Sensei. So sumimasen, Sensei.
Okay, I got it.
And is it okay for you to share your screen? I mean, is there any problem to share your screen?
Okay, I got it. Thank you.
Yeah. Okay, thank you, Sensei.
ミュートにしとかんと、これ音声がなんか微妙だね。
ただミュートにしとくと、喋るときにミュート外せばいいですよね。
なんかね、最初にオープニング
Yang pertama memberi kesempatan Dokter Rina kan? Ya, nanti Dokter Rina beri kita kesempatan moderat. Oke, dia good. Thank you, dia good. Ya, kasih. Iya, kasih.
Haha, 待合室に入った人を次々に許可していってるんだ。
Dia mungkin share screen-nya tidak di open sehingga dia bertanya kok tidak bisa dimunculkan gitu. Share screen-nya
Harus dibuka dulu tuh share
ya,
screen-nya.
share screen dibuka untuk
Harus dibuka oleh host,
oleh host, baru mereka bisa buka. Dia mau coba masuk itu, cuman kayaknya kok nggak bisa gitu. Biasa dia mau coba-coba dulu. Dibuka aja dulu. Share screen-nya.
Yang orangnya mati. Apa nama Paulina Lestari kan? Paulina Lestari, oke. Tadi dia sakit gitu. Sempat mati kami.
Mafumi Okimoto Sensei.
our clinical lab, our nursing lab is like a hospital setting. So the students actually are practicing in the simulation lab, and we also do face simulation. So we have some
dulu yang space, Ibu Rektor dulu space.
people in the community, especially the elderly, they would like contribute in the teaching. So that's why they came and did a simulated patient. So we set up
Ada Prof. Oslan.
Sampai Prof. Budu.
Ya.
Prof. Budu, ya. Mas.
Apa rencananya, Prof?
Ya.
Jam berapa rencananya, Prof?
Resen ya, sudah hampir mulai, Dinda, Pak Resen. Sementara Ibu Rektor.
Oh, siap, Prof.
Ibu Rektor langsung begitu datang beliau karena selagi di setting. Langsung kita mulai.
Siap,
ya,
siap, Prof.
lagi di setting di rumahnya beliau.
Iya. Makasih, Prof.
And we realized that the teamwork actually because we use it there. So we realized that teamwork, critical thinking, and so we launched this kind of simulation, and we really think that labor intensive.
Ya, sudah kelihatan, Prof. Sudah kelihatan. Sudah ada kayaknya, Dr. Rina. Ibu Rektor sudah ada. Saya tunggu sebentar ya. Ya, sudah siap, Mindi? Tidak. Ada? Tidak apa-apa. Ya. Dr. Rina, Pak Gubernur kira-kira 2-3 menit lagi.
Ya, kita tunggu, Mi Prof.
Dua menit lagi.
画面をスライドショーして、スライドショーしたら始まったっけ？この画面共有しとったらいいんだよね。画面共有。なっとるよね。いけたよね。
ミュートしといた方がいいかもしれない。ミュートしとかないと先生の声がガタガタに。
あ。
ボル先生、日本語でいいね。
はい。お願いします。
日本語でいいでしょ。
はい。お願いします。日本語どうぞ。みんな日本人だから大丈夫。大丈夫です。学長も日本語ペラペラですから。
新しい共有に変なことしちゃった。共有停止。
Ya.
Sudah bisa dimulai, Prof?
ちょっと待ってください。
Ya.
もうみんな揃えましたか？
はい。
はい、できましたよ。
Baik, saya mulai saja.
はい、どうぞ。
Vera di mute dulu yang orang Jepangnya. Oke, baik, saya mulai ya, Prof.
どうぞ。
Assalamualaikum warahmatullahi wabarakatuh dan selamat pagi. Good morning, everyone. I'm Dr. Rina Masada, the host of this webinar. This webinar is held by Faculty of Medicine, Hasanuddin University, Makassar, Indonesia. The title is Management of COVID-19 Patients in Hiroshima, Japan, and Makassar, Indonesia. Yang terhormat Bapak Gubernur Sulawesi Selatan, Profesor Dr. Insinyur HM Nurdin Abdullah, Master of Agriculture. Yang terhormat Ibu Rektor Universitas Hasanuddin, Profesor Dwi Aryastina Pulubuhu MA, dan Dekan Fakultas Kedokteran Unhas, Profesor Budu, spesialis mata, Master of Medical Education. Please let me speak in Bahasa Indonesia and English. And first, I want to introduce our speakers. The speakers from Japan is Mafumi Okimoto MD. She is a Chief Director of Respiratory Medicine of Hiroshima City, Funairi Citizen Hospital. Then Professor Oge Hiroki MD PhD. He is a Chairman, Department of Infectious Disease, Hiroshima University. And also he is a Chief of Infection Control Headquarters of Hiroshima University Hospital. Then we have Professor Nobuaki Shime, MD, PhD. He is a Chairman, Department of Emergency and Critical Care Medicine, Hiroshima University and Hiroshima University Hospital. We also have three of speakers from Indonesia. First is Professor Budu, and also Professor Dr. Mansur Arif, PhD, Specialist of Clinical Pathology Consultant. He is a Director of Wahidin Sudirohusodo Hospital Makassar, and also Professor Dr. Syafri Kamsul Arif, Specialist of Anesthesia. He is a Director of Hasanuddin University Hospital. Well, we will start soon. First, I will invite Professor Dwiya, our Rector of Hasanuddin University, to give opening remarks. Please, Professor Dwiya.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
And very good morning to all of us. Of course, I would like for the first to greet our important guest, Excellency Mr. Governor of South Sulawesi Province, Professor Dr. Nurdin Abdullah. Thank you for joining the international conference held of Faculty of Medicine, Universitas Hasanuddin. And also I would like to greet to all distinguished speakers coming from several universities in Indonesia and Japan, and several hospitals. Okay? I noticed here together with us Mafumi Okimoto, medical doctors, and Professor Ogi Hiroki, medical MD and PhD, and also Professor Nobuaki Shime, MD, PhD, and some from Indonesian speakers, our colleagues, Professor Budu, Dean of Faculty of Medicine of Universitas Hasanuddin, and Professor Syarif Mansur, Director of Wahidin Sudirohusodo Hospital, and also Professor Syafri, Director of Universitas Hasanuddin Hospitals, and other speakers. Together with us is Vice Rectors, Dean and Vice Deans, and several professors, and of course to all dear participants, including the students. For the beginning, let us thanks to the Almighty of God for for His blessing to all of us, that right now we are in a good health all, and that possible to join together in the international webinar with a very important topic, I think, that is management of COVID-19 patients in Japan and Indonesia, and held by Faculty of Medicine of Universitas Hasanuddin. Ladies and gentlemen, today there are two international seminars held in the morning earlier held by the Faculty of Nursing and right now Faculty of Medicine. So thank you. I appreciate very highly to inform, and also I'm very happy that Mr. Governor is together with us to inform the Mr. Governor, Excellency Mr. Governor. Universitas Hasanuddin is very productive and very active in conducting several international seminars with a very important topic, how to face the COVID-19 problem in all places. Ladies and gentlemen, crisis can happen at any time, including the pandemic. If we look back to the history, several history of crisis of the pandemic, we think that we can reach the analysis and conclusion that we can learn from its experience. So right now we know during the pandemic COVID-19, every hospitals and the clinician as the frontliners meet with the unexpected challenge, especially in giving the services of treatment to the patient of COVID-19. So we have to deliberate or develop the strategy to manage the patient. For the most, to me, is how to manage to treat the patient that understand clearly to notify the common symptoms of the COVID itself, COVID-19 itself, such as a fever, coughing, and like breathing problems, and how the doctor, the clinician, during their consult to the doctor, the clinician, to make them understand that whether they need to be hospitalized or just having treatment at home because they meet only such kind of mild symptoms. This, I think, part of the to manage the patient. I guess otherwise they will all go to the hospital. Experience in Indonesia, most of the patients having panic or stress when they meet the COVID symptoms, COVID-19 symptoms, and most of them directly request to be hospitalized, come to the hospital and hospital. At the same time, we honestly to say in several towns in Indonesia, having no adequate beds or hospitals for take care of COVID-19 patients. So another side, I think we need to ensure also the facility, the policy and the practice that can minimize the risk of the clinician or the nurse when to ensure when they treat the patient. So I think we need to develop the strategy, the protocol that should be implemented to the frontliners and also to the patient upon their arrival, before their arrival to the hospital, upon their arrival at the hospital, and also throughout during their stay in the hospital. And even also, I think we need the protocol how to let them to be having treatment at home. So many things have to be developed, I think. So, Mr. Governor, Excellencies, and speakers, and ladies and gentlemen, I believe in Japan have a very best experience and having, of course, advanced hospitals and the system in giving better treatment to the COVID-19 patient. Then we can learn from them. But other side, in Indonesia also have a very variety experiences in giving service to the patient, which from all level of understanding and discipline, or level of discipline in following the protocol, the health protocol as a COVID-19 patient. So at the same time, Indonesia, honestly, we have a very limited hospital equipped for our critical care, for a critical care patient for the having the virus. So, of course, by this situation in Indonesia, the hospital and the management of the clinician and the management, they can develop the very innovative strategy to meet the challenge. And I think Japan also need to learn from us, a lot to be learned from Indonesia. So I think we are here to discuss this very important problem. And Mr. Governor, Excellency Mr. Governor, Speaker, ladies and gentlemen, I think university must have the safe for better life post COVID-19 or in the new era, in the new normal era. University, we know, have a very vital importance role for develop better future of society. So from here, from the university, we can promote a very multidisciplinary approach to take care of the patient, to manage the patient by the very competence of clinician, hospital, and the system. Of course, by also providing a very appropriate and excellent and innovative services. So again, we are here to this effort, and I would like to extend our hearty appreciation to the Mr. Governor for his kind attention. And in the province of South Sulawesi, Universitas Hasanuddin is given a very big role as part of the system, the management of COVID-19 treatment for the people. Thank you, and also thanks to Faculty of Medicine, and I also highly appreciate for the dean and the team for making this international webinar can be held with the very excellent speakers. And thank you, of course, for the speakers for joining, for your time and your information. Thank you for all the participants, and I do hope this international seminar webinar will be have a good result after this and can be followed by the government and the hospital, of course. Thank you very much. Wabillahi taufiq wa hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Terima kasih Ibu Rektor. Suara saya kedengaran ya?
Ya, bagus.
Suara saya kedengaran, Prof?
Kedengaran, diterima. Oke, bagus.
Ya. Baiklah, terima kasih untuk Ibu Rektor. Berikutnya kami persilahkan Bapak Gubernur, Pak Nurdin, untuk membawakan kata sambutan, sepatah kata, dan juga sekaligus membuka acara webinar ini. Silakan, Pak.
Tertutup, Pak Gubernur.
Sudah ya? Ya. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Selamat pagi. Ohayo gozaimasu.
Ohayo gozaimasu.
The honorable all speakers and participants of international webinar, especially the speaker from Hiroshima University, Rector of Hasanuddin University, Professor Dewi Aristina Pulbuhu, speaker from Hiroshima, the Honorable Mafuni Okimoto, the Honorable Professor Oge Hiroki, the Honorable Professor Nobuaki Shime, and speakers from South Sulawesi, Professor Dr. Budu, Professor Mansur, Professor Safri Kamsul Arif, and all participants of the webinar. First of all, I would like to express my appreciation. I believe this international web seminar is a very important agenda. We can share about management of COVID-19 pandemic in Indonesia and in Japan, especially in Hiroshima. As we know, Japan is revoked the status of emergency response. Japan has started their normal life, and since then, Japan found no problem in returning to their normal life. While Indonesia, trend of effective victims of COVID-19 is significantly increasing. We are expecting that the method used by Japan, especially Hiroshima, in handling the COVID-19 pandemic, can be a reference for us in Indonesia, especially in South Sulawesi, to control the spread or even to cut the chain of COVID-19 spread. Knowledge and technology used by Japan can be synergized to cut the chain of COVID-19 spread. My honorable ladies and gentlemen, cooperation between government of Japan and government of Indonesia, particularly with province of South Sulawesi, has been established since I served as region of Bantaeng for 10 years, and this relationship will always continue until now, as I am receiving the honor to be the governor of South Sulawesi. High quality of Japanese health examination technology and knowledge is what Indonesian people needed today, especially in dealing with this COVID-19 pandemic. For the reason, I'm expecting for a well-established and a well-maintained cooperative relationship can be even closer, mainly in increasing cooperation in health sector. In South Sulawesi, COVID-19 outbreak is not only a crisis in health sector, but also implicated toward all sector of human life and even slows down the economy, not only at the regional level, but on massive and significant economic of the world. To maintain economic resilience, the government, through the social safety net program, have been providing assistance to people affected by COVID-19, such as laid-off workers, life of victims, the poor, and people who cannot do any activities due to restriction, either due to physical distancing or social distancing. As well, with the food security and other sectors, the government is working on right formula of productive and safe community protocol of COVID-19. A new life order to remain active and productive by maintaining strict hygiene and health protocols and standard better now as the new normal life. Innovation of provincial government of South Sulawesi in handling prevention of the spread of COVID-19 through COVID-19 tour program, which is a collaborative program with a number of hotels in implementing self-isolation as a quarantine place for people in monitoring, ODP, patient under supervision, PDP, and people without symptoms, OTG, making it easier to supervise and minimize the spread and to revive the economic sector. That would be the end of my remarks in this opportunity. I'm expecting his collaboration could provide benefit for both parties. And also we could soon find a vaccine that may reduce the number of victims of COVID-19. I would like to deliver in Nihongo. Sanka sano minasama. Honjitsu, coronavirus ni kanshite, Nippon no kenko shindang ya chisiki to gijutsu wo Minami Sulawesi Shu no kanri wo hikakuteki ni manabitai to omoimasu. Minami Sulawesi ni wa kono pandemi no eikyou de kanko dake de wa naku, keisai mo tottemo okina eikyou ga okonawarimasu. Nihon mo coronavirus de keisai ni mo eikyou ga aru to omoimasu ga, そのために日本のやり方を本日学びさせていただきたいと思います。最後にこのセミナーがみんなのために参考になることを望んでいます。私からの依頼もコロナウイルスのワクチンが早めに見つかることも望んでいます。皆さんの健康を祈っています。本日誠にありがとうございます。In the end, let us pray together to ask for His blessing for all steps we choose on acceleration of handling the pandemic of COVID-19, not only in South Sulawesi, but also throughout the world. Once again, I thank to all participants attending this webinar. May this webinar could give a good solution to accelerate the break of the chain of COVID-19 pandemic spread in South Sulawesi. Dengan mengucap Bismillahirrahmanirrahim, seminar nasional internasional pada pagi hari ini atas izin Ibu Rektor saya nyatakan dibuka dengan resmi. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih kepada Bapak Gubernur. Before we go to the next session, for Sensei from Japan, our governor is graduated from Fukuoka, Japan as well. So thank you very much. So the next I will deliver to the moderator. Our moderator today is Dr. Diah Gemala, MD PhD. She also graduated from Japan. She will as the moderator for this webinar today, please.
Thank you, Dr. Rina. Good afternoon, dear Honorable Professor, doctors, all participants, and all colleagues. Welcome to this webinar, and I'm Diah Gemala Ibrahim as your moderator today, and it's a great pleasure and honor for me to take a part of this webinar. And I would like to say thank you first to the 5 organizing institutions, including the Hasanuddin University, Hiroshima University, Funeri Citizen Hospital Hiroshima, Provincial Government of South Sulawesi, and Japan's Graduate Association of Indonesia, or PERSADA. So without the collaborations between these 5 institutions, we wouldn't have this seminar. So today's presentations is about the preparedness and response of hospital in both countries, Japan and Indonesia, in accordance of its own laws and authorities for COVID-19 outbreaks. So what the committee have done is brought together the experts from both countries who can share their experience dealing with this COVID, patients on the front line, and they will be sharing their best practices, policies, and other useful information for all the participants and or for all the clinicians to manage and fight for the COVID-19 pandemic. So to all the professors, thank you for the collaborations to participate in this webinar. And 貴重なお時間を割いていただきありがとうございます。今日はよろしくお願いします。So let me quickly guide you through an arrangement of this webinar. So this is a panel discussions, and each speaker may have 10 minutes to present his or her presentations. And the Q&A sessions will be open at the end of the presentation or after all of the speakers have finished. But you can leave your comment or question for all the participants in the chat sections through your Zoom applications. And we will organize all of the questions at the end of the presentations. And last, before I move to the main presentations, I would like to make sure all of the speakers and participants are mute except for the person speaking. So we are going to start to the next sessions, the main presentation from all the speakers. And first, I'm pleased to welcome Mafumi Okimoto, MD, from Hiroshima City Funeri Citizen Hospital. She and her team is mainly manage COVID-19 patients in Hiroshima, and she also involved in the clustering management program in Hiroshima. And today she will be sharing with us her successful management of COVID-19 clusters in Hiroshima. And to Sensei, the floor is all yours.
Thank you, Chairperson. Ladies and gentlemen, I am Dr. Okimoto. Nice to meet you. I'm glad to have a chance to attend to this meeting.
Wala bawa headset, Pak. Wala bawa headset.
Sorry. これです。
それダブルクリックしたら、これで下のあれをプレゼントボタンを押したら、一番下の。
一番下。あ、それです。
それを押したら。2枚目じゃん。
で、1枚目。Today, I'm going to talk about our experiences of managing COVID-19 clusters in Hiroshima in the last 3 months. Although the word successful might be an overstatement, we think that our strategy worked well so far. Before starting to talk about our experiences, let me introduce our hospital, Hiroshima City United Citizens Hospital. Hiroshima Prefecture is located in the western part of Japan, and the population is near 3 million. Our hospital is located in Hiroshima City. Funari Citizens Hospital is one of the hospitals for designated infectious diseases, including COVID-19 in Hiroshima Prefecture. We have an isolation ward. Sorry.
その名前なの。スライドショーかな。下のスライドショーしてみてください。下のスライドショー。下のスライドショーって
押せない。もうこっちがスライドショーになってしまう。
聞いてみて、can you see the more first slide?
Can
you see my slide?
Yeah, we can see your slide. We can see your slide.
Yes, we can see also your slide.
So we can see your slide, Sensei. So just go ahead.
今2枚目です。あれが私の。
I think put in the slideshow.
Yeah, maybe you have to make it slideshow, Sensei.
Yes, yes.
Slideshow. And then enter.
Continuing. I'm sorry. We have an isolation ward with 30 beds for mild to moderate infectious diseases. These two pictures show the members of Team COVID of our hospital. The left picture shows a part of nurses working in the ward for COVID patients. In the right side shows doctors consisting of 3 respiratory medicine specialists and 1 infection diseases specialist. What is it? これでいきます。先生の画面。The spread of new coronavirus has overwhelmed countries around the world. Each country has been taking various measures like citywide lockdown or encouraging to perform PCR testing even for asymptomatic citizens. Japanese strategy has been criticized because relatively loose restriction and small numbers of PCR testing. However, recently, Japanese strategies to manage COVID-19 is reviewed and started to be called a Japanese miracle because the number of fatalities is still low and the number of infected people has been decreased. Sometimes people say that it's just lucky. However, I don't think so. The major part of the Japanese strategy has been the cluster-based approach. In Japan, 600 local health centers were set up for each community health systems. These centers track every COVID-19 cases and close contact persons in each region. By active epidemiological survey, the centers are trying to identify and monitor clusters very closely. PCR tests have been performed for these people actively, and positive patients were hospitalized and isolated. By this active survey, expert members in Japan defined characteristic of transmission form of COVID-19. The experts called the risk factors of COVID-19 transmission as Sanmitsu in Japanese. Sanmitsu means 3 C's, including closed spaces, crowded places, closed contact settings. Situations forming 3 C's were Japanese-style pubs, karaoke room, music live houses, waiting area of hospitals, and so on. According to the finding of 3 C's, Japanese government demanded people to change their behavior and avoid 3 C's situation seriously instead of implementing citywide lockdown. I think that the Japanese strategy has worked very well so far. I also think that there are other factors in Japan. Japanese universal health insurance system has made people easy to visit hospitals and receive examinations such as CT scan. And Japanese traditional customs are also playing a role. Since before, in Japan, we have been wearing masks when we feel sick. And we have traditional greeting styles like bow, ojiki, instead of shaking hands, hugging, and kissing. Even before the middle of March, as you see, COVID-19 outbreaks occurred in Hokkaido, Tokyo, Osaka, but not yet in Hiroshima. In Hiroshima, there are few patients until the end of March, we could have a time to set up the facility for COVID-19 in our hospital. First, we started a consultation room for outpatients with fever. We also examined close contact persons in the same room. Although many patients had worried about COVID-19, there were many patients with other febrile illnesses. We focused to examine, diagnose, and treat properly. So we were able to diagnose many other diseases, including emphysema, bacterial pneumonia, drug-induced interstitial pneumonitis, and so on. Second, we prepared local isolation ward where 16 patients with moderate symptoms can meet at the same time. From the beginning of April, we added 14 beds for patients with mild symptoms. Meantime, we re-educated related staffs, including nurses and other medical workers, how to use PPE and prevent themselves from infection. Collaborating with the local health centers, we supported the management of the clusters in Hiroshima. The slide shows numbers of COVID-19 patients in various prefectures. At this point, the patients in Hiroshima is increasing in a few days. 2 large clusters were identified at this point. This map shows the current situation of COVID-19 occurrence at May 28th in Hiroshima Prefecture. Some clusters in these red areas. Our hospital is located in Hiroshima City. This slide shows the clusters in Hiroshima Prefecture. There were 5 clusters. We accepted patients from these groups, indicated with green color. This slide shows the first cluster in Hiroshima. The first patient worked in a beauty salon. She visited the hospital because of fever and respiratory symptoms and diagnosed as COVID-19 on March 25th. Some hostesses of a nightclub were her customers of hairstyling. The healthcare center tested all close contact persons. 2 hostesses without symptoms were positive. All of these 3 positive patients were admitted to our hospital. Because of the occurrence of the cluster, the nightclub was closed. After this news, the regional government requested citizens not to visit these nightclubs. After this request, no patients was found from these nightclubs and related shops. The next slide shows the cluster in nursing home. First, an old lady had a fever from April 4th and admitted to a hospital. She was diagnosed as pneumonia due to COVID-19 in April 8th. In April 9th, another old lady was hospitalized and diagnosed as COVID-19. As soon, active surveillance was initiated, and it was identified that one lady who worked at these 2 women's home to take care of them had symptoms like COVID-19. She and her family members were all positive for COVID-19. Moreover, it was found that the second lady also used the nursing home for daycare service. The people who used this facility received PCR test. 36 out of 280 close of contact persons were positive, and all positive patients were admitted to several hospitals. By this management, the cluster did not expand more than expected. This slide shows the largest cluster in Hiroshima. First, some college students had a party at the restaurant in the end of March. 2 of them were diagnosed COVID-19 on April 6th and 7th and were admitted to our hospital. On April 12th, 5 residents of mentally handicapped facility had a fever on the same morning and they visited our hospital. They were all positive for COVID-19. On April 13th, a few more residents had a fever and they were also positive. All facility personnel, including their family members, were tested for COVID-19. As a result, 44 residents, 13 staff members and 4 family members were confirmed to be positive for COVID-19. At this point, we realized that these young staff joined the party and started to work in the facility from the beginning of April. Unfortunately, she was almost an asymptomatic patient and transmitted the virus to the facility. The biggest problem of this cluster was that some residents could not tolerate hospitalization because of their mental handicap. For them, it was difficult to understand and inform their symptoms by themselves, and it was also hard to have a rest in beds. COVID-19 positive residents with moderate or above symptoms were hospitalized with facility staffs who were also COVID-19 positive. The staffs kindly helped the nurses by observing the residents. If they got into severe condition, we transferred them to intensive care unit of the other hospitals, including Hiroshima University Hospital. More than the half of patients with mild symptoms were managed at the facility. For 2 weeks, doctors from several hospitals visited the facility in rotation to observe the residents and staff members. We divided the facility into 3 areas: green, red, yellow. Green is for negative residents. Red is for positive residents. Yellow is for those who have turned from positive to negative PCR. Using this zoning strategy, we could prevent local spread as possible. At the beginning, there were 47 patients in red space, but now, 7 weeks later from the onset, the number of patients in red area became 0. There is no new patient. The cluster is successfully contained. I want to show our criteria for transferring patients to ICU. As you know, in COVID-19 patients, if it started to deteriorate, the progression of disease is very quick. If we could observe changes of oxygen saturation and oxygen requirements as shown, and changes of chest X-ray and CT findings, we urgently transferred patients to ICU. Until now, we sent 4 patients to ICU. Although 1 of 4 patients was passed away because of acute renal failure, 3 patients were recovered and transferred to general wards. This slide shows the change of the number of COVID-19 patients in Hiroshima. Here and here is the date of cluster occurred. And no new COVID patients have appeared since May 4th. I believe that we have successfully contained the clusters in Hiroshima at the point. This is our conclusion. 5 clusters of COVID-19 occurred in Hiroshima since the end of March 2020. 1. According to Japan's strategy to COVID-19, local health centers and COVID countermeasure teams focused on cluster-based approach and defined characteristics of transmission form. The clusters were successfully contained so far. If a cluster of COVID-19 occurred in a facility for vulnerable people, it is necessary to establish a support system that the hospitals, the facility, and the local health center work in cooperation. 3. Before the expected second wave, we need to upgrade our system to deal with a huge number of patients like New York City. I hope the spread of COVID-19 settles down soon, and I hope things get back as soon as possible. Thank you.
Thank you, Sensei. Thank you for the presentation. Hontoni arigatou gozaimasu. So we can continue to the next presenter because we have a panel discussion. So all of the questions are give at the end of the presentations. So for the next, we have Professor Budu Maju, MD, PhD, ophthalmologist, Master Medical Educations, and besides serve as the Dean of Faculty of Medicine, Hasanuddin University, he is now serving as the Chief of COVID-19 Response Acceleration Task Force of Hasanuddin University. He is also an alumni from Toyama University, Japan. He will be sharing about the strategic management of COVID-19 in Makassar. To professors, the floor is all yours.
Thank you. Thank you, moderator. Let me also, I will share my slide, and I try to have the time for 10 minutes. So maybe this is not so enough time for me, but I hope the material will show us how the general strategy management of COVID-19 in Makassar. Bapak Gubernur and Rector, on all of the speakers and attendants of this webinar, international webinars. Indonesia have the first coronavirus in the 2nd March 2020. And at the time, we see here that the first cases come from the location of Depok, which is around the west of Java. But after some days, 1 week, the cases increase frequently until the March. And then South Sulawesi is located in the middle of Indonesia. And also we can see the first cases of 19 in Makassar. This is the patient, he went to Umrah on February 2020 and returned on March 3. And then just for the patient first died on Sunday and 15. And we saw to all of you that South Sulawesi have a total population 8.83 million, and Makassar is 1.5 million. 1 week from the first, 30 March 2020, we found 27 patients confirmed with COVID-19. And 1 week after, on April 6, 2020, we see the patient increase to 3 times from the first. It's 72 patients confirmed with COVID-19. And May 9, 2020, and the 1st of May, 1 month ago, the positive COVID-19 in 710 people. And then this is the very fresh data from the task force. On June 3, 2020, now we have 967 with COVID-19 positive. And the cluster of COVID-19 in the city of Makassar. City of Makassar is the capital of South Sulawesi. Ladies and gentlemen, then we can see this is the task force office of COVID-19 of Makassar city. We can see the data from ODP, PDP, and positive, yeah. And we can see that there is many patients from day to day have recovery from the disease, but also we can see from 3 of kind of cases also increase from day to day. But we're very happy to see that South Sulawesi in the 1 province in Indonesia have the recovery rate is 64%. It's the first province in Indonesia have 64% of recovery from that. And the first COVID-19 when it's fine. Firstly, in the 1st of March, there is Saturn, and from Saturn to panic, and the initial problem can found anywhere. The first is the readiness of our hospital, because we don't have experience how to handle the viral like COVID-19. And the second is at the time, on the 1st of March, we still have a limited diagnostic laboratory. Because for a long time, we just only prepare laboratory for the other infection disease. Including also the readiness of health workers, because at the time we don't have enough health workers trained by how to handle the virus. Also, personal protective equipment also is very limited in numbers, including community ignorance and a partiality of information anywhere. So at the 1st of March in Makassar, in maybe in around of Indonesia, is such an fun. But we very happy to report that we fortunately, because some of donations from individual and the partners of province, a partner of Hasan University, come to help the limited of prevention sorts, and also supporting from the government of Sulawesi, and also we also accepted some supporting from the Minister of Finance, Ministry of Health, then the Ministry of Education and Culture. So in the March, the 1st of March to the 1st of April, we can handle the cases of COVID-19, although in the limited HPD. So maybe like in many countries in the world, the COVID-19 task force is also not only in national, but also in regional, local, and units. In South Sulawesi, some of district residents also have the like local task force. Even in the unit like in Hasanuddin University, we have also we call Satgas COVID-19 Unhas, and we collect some equipment and material to help the health workers in the hospital to use in every daily in COVID-19 services. What the task force in Makassar, Sulawesi? The first is a preparing referral hospital, and the second is preparing diagnostic laboratory, widely and partially let down. Also, we have massive and central quarantine or partial lockdown, and also massive and aggressive testing of COVID-19. Let's us to see one by one. On the 1st of March and April, Governor released some recommendation to handle some limitation of the referral hospital, to make sharing health workers, to make sharing laboratory, to make sharing equipment, and to make sharing some material for COVID-19 services. As we can see in the slide, the government also determined which one the hospital is the referral, the main gates of referral, how the hospital makes sharing together, and also determine what the hospital is the first main gate of 19 in the city. We have 46 referral hospitals, but we have 5 main referral hospitals. This is the Rumah Sakit Dadi, is main hospital of Dadi, Hospital Israel Rakyat, Hospital Daya, Hospital Hasan University, dan Hospital Wahidin Sudirohusodo. We have around 300 beds totally. This is the rule of referral system in managing of COVID-19 services in Makassar. From primary healthcare, we call Puskesmas here, and also 46 referral hospital, when they accept like mild COVID-19 they have to refer to Rumah Sakit Dadi, Dadi Makassar Hospital and Sayan Rakas hospitals. And the two hospitals then hospitalized moderate PDP. When PDP and PDP crisis and have need to enter the ventilator room, this hospital referred to them our main hospital, Rumah Sakit Wahidin and Rumah Sakit Unhas. I would like to show how the governor and the government of Sulawesi preparing the Sayan Raksa Hospital to have nursery like hotels. Now, by June 2, 2020, total beds of Sulawesi Province Hospital, we call Sayan Rakyat, 98 total beds. ICU 4 beds, 5 ventilators, and recently there are 58 patients and there's only 1 in ICU. This is located in the near from Cholin, Makassar. And then Rumah Sakit Dadi. Rumah Sakit Dadi also have many beds. 200 total beds, including isolation room 150, intensive care unit 10 with 7 ventilators, pediatric intensive care we have 4, and delivery room also because some patients with delivery also have COVID-19 plus positive. Mother and child operation room, recovery room, and now Rumah Sakit Dadi is the main referral of moderate for COVID-19, nurse 140 patients with 5 patients. When they enter to the crisis, they have to send to our main referral hospital, Wahidi Sudarhusodo and Hasanuddin University Hospital. We have 2 diagnostic labs, Hasanuddin University Laboratory and Laboratory of Makassar City, and we can make diagnostic for COVID-19 around, if totally we can diagnose around 900 to 1,000 per day of the sample, because sample is come from many districts in Sulawesi and also from main referral hospital to make sure what is the 9 confirmed or is not confirmed. This is very interesting to inform all of you. Our task force of Sulawesi province preparing some hotels for accommodation of 4 health workers. In other, the health workers can go back to the infect the other person in the home, also maybe around the environment. So they have to be accommodated in many hotels. Also, patients COVID-19 also have special hotel for to make quarantine for them. We have 2 hotels, Hotel Dalton and Hotel Max One. This is for health workers. Now we have 566 health workers, including quarantine in our 2 hotels. But for COVID-19 patient for quarantine who is not entered the hospital, we quarantine them. In other, they don't infect the others. They don't infect the environment. So the purpose of Sulawesi prepare 5 hotels in Makassar City, and now we have 601 COVID-19 patients now live in the 5 hotels in the Makassar City. This is just only one sample, the Hotel Max One. This is for health workers. During they live in the hotel, the transport prepared for for fresh environment, fresh nutrition, increasing the immunity, prepare like who live in the hotel, so they can suffer and recovery faster than when they don't enter the quarantine of hotel. This is just only one example of a hotel for health workers. This is example for COVID-19 patients. Hotel Swiss Bell, this is near from the beach of Makassar. Every day, the patients bring to the sunrise and also preparing like for religious activity, and also learned how to cover the COVID-19 disease. We have 5 hotels like Hotel Swiss Bell. This is some COVID-19 patient activity in the hotels. So some of them, maybe 90%, 95% recover from their disease and go back to his home. And after go back to her house, there will be a COVID-19 data for communication, information, and education for community where they live. So this is very innovative program for us, and we can see. We also after collect patient to the hotel after make service patient in the hospital. The local government of Makassar also make massive rapid tests. They went to the markets, they went to the community location to test. Like, for example, this is for markets, traditional markets. There is 4,880 people who joined the rapid test, and the team found 204 reactive product. The product is 204 reactive. Like in directly to community, 5,058 people, and there are 97%. There's been total 97 reactive of rapid test. When the rapid test is positive, they directly to bring to the hotel for joining quarantine with the hotel and waiting for swab for PCR to be delivered to our main laboratory in Hasanuddin University lab or in Makassar laboratory. In the Parkir area, 515 among of them is positive for reactive. Ojek online also 1,500 more. There are 22 of them is reactive positive of rapid test. Trans Studio Mall also 423 people, and 5 among of them is reactive positive. This is island Kodingaring Island. Total population done rapid test is 1,102, and task force found 124 with reactive positive. All of them bring to Makassar city, and then including in the member of quarantine of hotel. This is isolation and quarantine of COVID-19 in the hotel. Now is 601. There many still have room for the new one who will become later. And we can see the outcome of interventions. The first is we can see that from time to time, this is the first 40 days from the first of partial lockdown. The number of cases is 225, And then in the middle of partial lockdown, we found 46.4%, 320. Maybe this is the new cases, but after 14 days from partially lockdown, the case decreased to 20.1%. This means that the result of our interventions is made decrease of the new cases in Makassar. Like this one as well. Case decrease from time to time, 42.6% to 39.8%, and then the last in the 14 days after, just only 70.6%. The next, this is the daily trends of COVID-19 and estimation of reproduction value of South Sulawesi province. We kept this data on June 2, 2023, and we can see in the 1st of March, the RT is 4.14, but directly decrease one.
Color kan kata misalnya.
And then after we make like a partial lockdown, the case then decreased to 0.97. We know that the limits of line of RT is better in below of 1. But after then increase again, and for the ends of May, so Sulawesi RT is 0.96, but middle of the 1st of June again increased little to 1.08. Maybe it is the effect of our last community of Ramadan and so on after the Eid al-Fitr day. But we hope day for day will be increased under the RT1. This is Makassar. But Makassar now for in the end of May is still 1.02. This is the estimation and daily trends of reproduction value of COVID-19 in Makassar, of city Makassar. So we can see that from the first RT is 3.8, but after mitigation and intervention, massive intervention, now 1.9 in around maybe the 1st of May, and also this one decreased significantly, 1.9 in the 1st of May. Just my slide, and thank you very much. We hope that this slide can show all of you how the government of South Sulawesi and Makassar city to cover cases of COVID-19 during the pandemic from the March to the 1st of June. Thank you very much.
Thank you, Sensei, for the very stimulating presentation. And next, I would like to invite Professor Ohgi Hiroki, MD, PhD. He is the Chief of Infection Control, Headquarters of Hiroshima University Hospital, and we'll talk about his experience and strategy to handle infections in Hiroshima University. So, to professors, the floor is all yours.
Dede, sini aja. Dede, sini aja. Jangan ke sana-sana. Ci.
Okay. Can you see this slide?
Yes. Clear.
Yes, Sensei.
Okay.
Okay, Sensei.
Thank you for this opportunity. I will talk about the infection control. This is a trend of Japanese COVID-19 patients. Japanese government declared emergency in mid-April, and then it's decreased. I'm going to look back this period in Hiroshima University Hospital. Our goal during this pandemic is to maintain our usual function. Our main task is advanced medical care, and fortunately, we could continue this function during this period. But another important task, education, we had to stop. Still stopping. Maybe we can start end of this month or next month. And COVID-19 job is additional task for us, and it requires manpower and many medical resources. So we have to find space for this. So at the beginning, we informed to our medical staff, we have to take care for severe patients like ventilator or ECMO patients. To find another space, we decreased outpatient visit. But to maintain our usual job, we didn't change the number of surgery. This is the data we compared with last year. The number of outpatient clinic decreased about 20% compared with last year. But we didn't change the inpatient number. And income was almost same with last year. With infection control, we faced several issues. First of all, in Hiroshima area, we don't have enough beds for patients. And second, we also faced shortage of PPE. And lastly, as Dr. Okimoto said, we don't have enough capacity of PCR testing. So we try to figure out these issues. About bed control, municipalities of Hiroshima placed control center in their office. MD and public health specialists and nurses are there. And once patients are identified, this center decided which hospital is suitable for these patients. For these severe cases, Hiroshima University Hospital accepted these patients. And other hospitals accept mild to moderate disease. In total, we prepared about 300 beds. This number was calculated from population of Hiroshima. The population of Hiroshima is about 3 million. So this number means 1 bed for 10,000 people. And control center also prepared hotel and homestay for asymptomatic people or mild, very mild disease case. So now bed control is getting better. Another issue, shortage of equipment. At the beginning, we don't have enough masks or gowns, but now it's improved. We have enough equipment. This is a manual of this university. In each situation, healthcare worker wear this kind of equipment. And PPE is very important to prevent infection of healthcare worker. But another important thing is zoning, because this virus contaminates environment surface of hospital. I can talk about ICU zoning. This picture is very beginning phase, early phase. They use this kind of equipment, but now we don't use anymore. Just cap on eye protection, N95 and gowns. This is the ICU bed in Hiroshima University Hospital. The bed is placed in negative pressure room, and there are 3 zones. Healthcare worker wear their PPE and enter the red zone. And after procedure, they remove PPE except mask. And after hand hygiene, they can go out to yellow zone. But still, they wear N95. So they remove the mask and again, hand hygiene. And finally, they can go out to blue. You can see these 2 doors between red to blue. Between 2 doors, there's a yellow zone. You can see the equipment in the yellow zone. This is from inside. But still, this red zone is contaminated. So we use ultraviolet disinfection machine. Only 5 minutes use of this machine, all kinds of bacteria and viruses eliminated in this room. Actually, I didn't believe this machine, so I tested. And surprisingly, only 5 minutes use of ultraviolet, almost all kinds of bacteria and fungus was eliminated, even if this kind of spore-forming bacteria. This is published data for MRSA patient's room. Usual manual cleaning is effective, but not enough. But ultraviolet disinfection cover this. So ultraviolet is very useful for disinfect of environment contamination. And PCR testing. PCR test is basically for symptomatic patients. But for infection control, we have to use this test for asymptomatic people, like before hospitalization or before surgery, or in case of nosocomial infection. But for this testing, we have to examine many cases of sample. So we use this machine, automatic. This machine can examine about 200 samples in each run. We don't need preparation of sample. Only we have to do is sample collection and switch on. It takes about 3 hours. It's very useful, but it's very costly, about $50 per sample. In conclusion, for second wave, we could gain time, so we have to use this time. First of all, early detection is very important. If we suspect nosocomial infection, we will check all healthcare workers or patients in that ward. PCR before hospitalization has been studied in several university hospitals in Japan, but the problem is the cost. We have to figure out this issue. And lastly, for teaching hospital, student education is very important, but in second wave, we have to stop it again. So this is very serious problem for us. Thank you for your attention.
Okay, thank you, Sensei.
Yep.
So before I move to another presenter, I would like to remind to all participants, so you can leave your comment or questions in the chat sections in your Zoom applications, and we are gathering it and we are delivering it to the presenters directly after all of the speakers finish. And next, I would like to move to the fourth talk, which will be by Professor Mansur Arif, PhD, clinical pathologist. He is the director of Wahidin Sudirohusodo Hospital Makassar, as a main referral hospital in Eastern Indonesia. And we'll talk about his experience and strategy to handle COVID-19 cases in Wahidin Sudirohusodo Hospital. And this is a Professor Mansur Arif, also is an alumni of the Hiroshima University. So to Professor, the floor is all yours.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. The honor of Governor of South Sulawesi, the honor of Bu Rector, and our guest speakers from Hiroshima University. Let me start my presentation. So before my presentation, I'd like to say a special hello to our guests from Hiroshima University that already mentioned that I'm also graduated from Hiroshima University. So konnichiwa, Okimoto Sensei, Hiroki Sensei, and Shime Sensei. Watashi mo Hiroshima Daigaku Shitsugesmashita. Niju sen mai desu. So I'll start my presentation today entitled The Experience and Strategy for COVID-19 Services in Wahidin Sudirohusodo Hospital in Makassar, South Sulawesi, Indonesia. First, briefly, I would like to explain briefly that Dr. Wahidin Sudirohusodo Hospital, located in Makassar, the capital of South Sulawesi province. Then established in 1947. Actually, very small hospital because just borrowed 2 words from Dadi General Hospital. Dadi is dedicated actually for mental health hospital, but by borrowing 2 words, one for surgery and one for internal medicine, and then become the general hospitals. And in 1957, become the type B hospitals, and also as well as the main teaching hospital of Faculty of Medicine of Hasanuddin University. and then in 1994 become the hospital class A hospitals and belongs to central government, to Minister of Health of the government of Indonesia. And then so many changes until 2006 become the technical executive under the unit under the Minister of Health, and for financing control, the supervision under the Minister of Finance. This the vision and mission of Wahidin Sudirohusodo hospitals until 2019, and then from 2020, our strategic goals until 2024 is to attain the national referral hospitals with the comprehensive and optimal service, with the mission establish the quality of healthcare, and also until to support the hospital networking in eastern part of Indonesia. The value and culture we serve with our heart, not without heart, but with our heart. And the organization structure, Hasanuddin Wahidin Sudirohusodo Hospitals, led by the managing director and assisted by 4 technical directors. One director of medical, nurses and supporting services, director of human resources and research, director of finance, and director of general and operational. And also president director assisted by at least 7 committee. And the brief profile of Wahidin hospitals, that we have total buildings 29, and most of them old buildings. Only one buildings that relatively new, less than 5 years, that integrated cardiac center, with the total area more or less 13 hectares. This is the location, the map of Wahidin Sudirohusodo hospitals. And the bed capacity now, about 1,020 beds, with human resources about 2,400. Also serve medical students, residents for about 1,000, clerkship for medical students 379, and nursing students about 86. So our center of excellence, 6 center of excellence at Wahidin Sudirohusodo hospitals. One is cardiac center, and one of them is infection center. So that's why Wahidin Sudirohusodo hospitals were established as also the center for during pandemic for COVID-19 patient. The scope of activity, services, health services, education and research. And this is the activity from 2019 to 2020. So we can compare the impact of COVID-19 pandemic in 2020. So we can see outpatient visit per day in 2018 and 2019, about 800 per day. And in April 2020, declined sharply until less than 300 visits per day. Emergency visit also, we can see decreasing. Elective surgery also decreasing very sharply from about 30 per day, less than 5 elective surgery per day. And emergency surgery also decreasing from 9, 8, 7, and now only average 3 emergency surgery per day. And bed occupancy rate, BOR, on April only about 20%, with average length of stay on April about 5.1 days. This is the decree of Minister of Health, the establishment of Wahidin Sudirohusodo Hospital as the COVID-19 referral hospitals in Indonesia by the Minister of Health, and follow up the decree from President Director of from Wahidin Sudirohusodo Hospital to establish also task force for COVID-19 management in Wahidin Sudirohusodo hospitals. The sudden problems during the first COVID-19 pandemic in Indonesia, one is personal protective equipment, PPE, and the second one is beds limitation, facility also, and also budgeting. Difficulty in obtaining personal protective equipments, mainly due to the lack of PPE available on the market. So PPE equipment is not available in the market, and even available, the price is so high. And at the same time, we must also rearrange the budget that we already prepared at the end of 2019. At that time, the budget was made in accordance with projected growth in health services in 2020, without taking into account the COVID-19 pandemic. Efforts and strategy. First one is unification of emergency unit, increasing bed capacity for COVID-19 patients. Third, increasing the capacity of supporting services, include laboratory and radiology. Rearranging nurse schedules. Reduce activity at central operating theater. This one totally different with our colleague from Hiroshima University, that they don't change the central operating theater activity. And 6, participating in COVID research. So emergency rooms, we have 3 existing emergency rooms before emergency section or emergency unit before pandemic of COVID-19. The first one is cardiac center emergency room, obstetric, and central emergency. Central emergency is the main emergency room, served for surgery and non-surgery, except for cardiac and obstetric emergency. So in the interest of efficiency of health workers and also PPE and the aim to reducing the risk of COVID infection for health workers. And then during the pandemic, cardiac and obstetric emergency room are closed and centralized at central emergency room. So with one triage facility for COVID-19 is sufficient for screening of COVID-19 patient, instead of to prepare one triage facility for each emergency room. So this is the main aim for unification of emergency rooms during the COVID-19 pandemic. And also, President Director of Wahidin Sudirohusodo Hospitals decree for building isolation for COVID-19, because even we have experience in pandemic cases like MERS-CoV, SARS, avian flu, porcine flu, etc. But the speed of transmission for COVID-19 is very fast. So we try to build new isolation. to overcome in case the COVID-19 cases is increasing and increasing, and as a top referral hospital for COVID-19, we have to prepare for severe cases. And also, we are also trying for expansion of building isolation. As we know, our hospital have one buildings, 3 levels buildings dedicated for infection center, but this building is not enough during this pandemic. So we are also expand to another buildings. Actually, that buildings is dedicated for VIP patient, but during pandemic, we use for COVID-19 patient with mild symptoms. Contingency palm buildings, that this is the condition, the renovation of our VIP rooms to be the rooms for COVID-19 patient with minimal care. So with minimal symptoms, we care in these rooms. This is the few small garden that can be enjoyed by the patients from the rooms. So make to reduce the tension and stress of the patient, because actually the condition of the patient become worse, actually not because of the infection, but most of them because of very tension and very stress to face the COVID infection. And for the nurse staffs, before on duty in the infection center ward, we give the coach how to use PPI, and this is the routine work from our senior hospitals to deliver how to manage their PPE during their task in the infection ward. Coaching all staff before duty on infection wards, and they get training from infection control team, how to use PPE and decontamination also. And we also give some quarantine for health staff that already mentioned by Prof. Budu, that provided by government of South Sulawesi province, include shuttle bus. So all staff who on duty in infection wards was quarantined in hotel for 2 weeks. So the health workers who are temporarily on duty in the COVID room are quarantined. The aim is to reduce the risk of contact and transmission with family, and also reduce the risk of rejection from a community around where they live. So after 2 weeks off, and then for work, so they return to work, but they placed in non-COVID ward. So this we give a rotation that after working at COVID ward, and then after 2 weeks off, and then return to work, then we place them in non-COVID ward, whether in polyclinic or other ward. So there is a rotation, and especially for all nurses who less than 60 years old and or less than 60 years, but without with comorbid to severe to serve the COVID care room also. So we care about the condition of our health workers. Medical checkups for all staff after on duty at infection wards. After duty for 2 weeks, all staff get medical checkup for assessment of risk of transmission during work in infection wards. This policy now, just 2 days ago, we changed the policy that the medical checkup to all staff, not only after duty 2 weeks, but before duty, we need the basic condition of the staff, because we want to know the potential transmission, whether they have infected or transmitted from during their work at infection center or outside of the hospitals. So this also need to be assessed, because some information that during quarantine in the hotels, sometimes they gather together, meet, and sometimes probably without masks. So laboratory radiology assessment also include nasopharyngeal swab, this one for all the staffs with infection symptoms. Quarantine, this is the condition, how the situation during the quarantine for our health staff when off duty. They gather, and unfortunately without physical distancing. So this is the potential for transmission each other from among the health workers. So after medical checkup, staff with abnormal findings, and we continue quarantine for another 2 weeks. So after 2 weeks, staff back to work in another place in the hospitals, like in polyclinic or in wards, but other than infection center wards. Triage team. So we unification of our emergency room. We need also additional 10 for triage. But in next few days, this 10 will not use anymore, because we already have a triage room. We are now building a new triage room that permanently will use and more comfortable for the patients. Screening for the patient. All patients who coming in emergency room will be screening for early warning system for COVID-19 by history taking, physical assessment, and laboratory and radiology assessment. And also our hospital conducting research, COVID-19 related research, at least now 4 or 5 COVID-19 related research conducting in our hospitals. One is solidarity trials involving more than 200 institutions all over the world. And second, plasma convalescence, plasma therapy. And then another research inside 011 and inside 013. And the last is stem cell therapy in collaboration with Korean CDC. And the only one hospital in Indonesia conducting this the study, stem cell therapy. And a standard of care for our patient is Aluvia, remdesivir, interferon, whether alone or in combination. And this regimen provided by free by solidarity trial. This is the situation in infection wards team who working in ICU. We are still using hazmat, not surgical gown. But I hope after this presentation and after discussion with especially our colleague from Hiroshima University Hospitals, we know now that in Japan, they don't need a hazmat gown like this. So also to reduce the need and budget for PPE. And also we have BLS2 for RT-PCR. So I think the only one lab in Makassar can release the result in the same day when we take the nasopharyngeal swab because we released the results in the same day in order to faster how to manage the patient, especially from emergency room, because we know boarding time is before we perform on RT-PCR, sometimes more than 5 days, 4 days, only for waiting the RT-PCR results. And we have a very standardized international standard for biology molecular. We have 2 negative pressure room and 1 positive pressure room. And also we have sophisticated radiology equipment served for COVID-19 patients. We have CT scan with 128 slices. And also we have media center for COVID-19 information. So regularly we give information, press conference to all, whether electronic or printed people. And we also have update dashboard COVID-19, then real-time dashboard, like how many people in monitoring, patient under surveillance, and also confirm patient. And until this one, I capture data from yesterday. 49 patients die in the infection center of Wahidin Sudirohusodo Hospital. Recover one nearly 100 with death fatality rate, I think about 6 or 7%. So to support also our difficulties in facility or even PPE, we also receive a donation, not only from government or other institution, but also donation from NGO, which we receive. And as the end part of my presentation, as I resume that before COVID-19 pandemic, our beds for infection center only about 38, but after during pandemic, we increased the bed capacity until 118, room from 12 to 54, and ventilator, we now have 12 unit ventilators, and this serves for all severe cases of patients with COVID-19. And hemodialysis also, probably the only one hospital in Makassar have facility hemodialysis for patient with COVID-19 positive. And as I mentioned before, RT-PCR lab, we are now using BSC level 2, and with 2 negative pressure room and 1 positive pressure room. And emergency room, we the unification from 3 emergency room to 1 centralized emergency room. I think this is the end of my presentation. Thank you for all of your attention.
Thank you, Prof. Thank you, Prof. So I would like also to introduce that Professor Mansur Arif is one of the alumni from Hiroshima University. So yeah, thank you, Sensei. And for the next presentation will be by Professor Nobuo Kisime, MD, PhD. He is a professor and chairman, Department of Emergency and Critical Care Medicine of Hiroshima University. So his team is taking care of COVID-19 patients at the severe stage in Hiroshima. And he will talk about the emergency and ICU services of COVID-19 at Hiroshima University Hospital. So Professor, the floor is all yours.
No sound at all.
Unmute.
Unmute, I think.
Sensei, sorry, Sensei, maybe you can unmute your. Sensei, sumimasen.
No sound.
Sensei, maybe you can increase your volume or you can unmute your Zoom. Sorry, Sensei, we couldn't hear your voice. Sensei Nobuaki Shime. Professor Nobuaki Shime. Sumimasen, Sensei.
Okay, I'm sorry. Can you hear my voice?
I could hear your voice now, Sensei. Thank you, Sensei.
Okay, then let me start my slide. Can you see my slide?
Yes.
Okay.
You can see.
Sorry, I'm going to start. My name is Dr. Shime from Department of Emergency and Critical Care Medicine, Hiroshima University. I'm going to talk about our experience of COVID-19 in our university hospital. So in our hospital, we have maybe 40 beds for critical care and also intermediate care. Of those 42 beds, we prepared 4 beds for designated COVID-19 care. So this is a slide from New England Journal of Medicine, and you can see when a patient had an onset of symptoms like fever, cough, or fatigue, some of them will have severe symptoms after the onset of 7 days or after the onset of symptoms. The symptom appears with dyspnea, and almost 5% of the symptomatic patient becomes very critically ill. So we in our university received most critically ill patients, and data for the 3 patients are described here. We actually received only 3 patients. All of them are male and middle-aged, and from the onset to admission to our hospital ranges around 5 to 7 days. That is consistent with a report from New England Journal of Medicine. And also the predicted mortality from Apache scores around 20%. All of them had received mechanical ventilation between 9 to 25 days, and one of the 3 patients had ECMO for 10 days. Fortunately, all of 3 patients were discharged alive. I will show you pictures of the 3 cases. You can see some infiltrates in chest X-ray here, and also in the CT scan, you can see several subpleural gland growth appearance
which is comparable to the typical picture of severe COVID-19 patients. This is the pictures of case 2. As you can see, the changes of lung damage is more severe compared with the first case. You can see bilateral infiltrates in chest X-ray, and also you can see in the CTs more severe ground glass opacities and also some consolidation, patchy consolidation in this patient. The last case is here, which is almost similar to the case 2, showing some ground glass opacities and also consolidations. So as you can see, the case 2 is the severest and requiring ECMO or therapy. In the literature, the changes in lung injury can be divided into 2 types. One is type low, in which the changes of lung damage is localized and less severe, and the lung is more compliant and also more less severe. In the type H, the lung damage is more severe with ground glass opacities and consolidations. And the lung is less compliant and more heavy and hard to ventilate. So it is thought that patients have changes of those 2 phenotypes, and finding the patient earlier and providing better ventilation management may help patient to progress their lung damage. So we apply lung protective ventilation for patients with COVID, as well as, which is similar to other ARDS patients. We provide lower tidal volume and lower pressure, higher PEEP, and most importantly, we would be better to suppress patients' spontaneous breathing to avoid lung injury. For the more severe patient, we apply ECMO and reduce mechanical ventilation as possible as we can to protect lungs. So this is one indication of ECMO for COVID-19 patients. So basically, we limit the application for patients with early in their case, and also relatively younger patients. There are 2 main indications with hypoxemia and hypercapnia. However, in the literature, the outcome of ECMO for COVID-19 patients is not good. So there is still a controversy whether should we apply ECMO for COVID-19 patients. This is the earliest study from Wuhan. In that, you can see that the mortality of patients receiving ECMO exceeds 60%, which is very bad outcome. However, in this country, we have a national network for providing ECMO throughout the country. We provide telephone consultations and also case registry, and also some advices in cases necessitating or requiring ECMO therapy for whole country. In the registry data, we found that although some were still on ECMO, but so far we found mortality rate of 24%, which is relatively lower compared with the data from other countries. And also, we found that patient received mechanical ventilation only, the mortality is rather lower. And also, you can see that in this country, as a first wave of COVID-19, we had 500 cases of mechanical ventilation, and which is relatively smaller compared with other Western developed countries. And this might be associated with better survival. As you can see in some literature in United States or Italy, more patients were died who underwent mechanical ventilation. Means reducing the number of necessitating mechanical ventilation might be important to provide better care or better ICU care for patients with COVID-19. I'm saying thank you for my all colleagues and also the Indonesian colleagues for providing me this precious opportunity to present you our data. Thank you so much.
Thank you, Prof. Thank you. Arigatou gozaimasu, Sensei. And the last presentations of this webinar, we have Professor Shafri Kamsul Arif, anesthesiologist, intensive care consultant, cardiovascular anesthesia consultant, as a director of Hasanuddin University Hospital. He is also serving now as a head of Indonesian Society of Anesthesiologists. And he's gonna talk about the identifications and critically COVID-19 patients in Hasanuddin University Hospital. So Professor, the floor is yours.
Thank you, Ms. Chairman. I try to prepare my presentation. Okay. Can you see?
Prof, bisa Prof? Yes, Prof.
Yeah, you can see.
It's clear, Prof. Thank you. It's clear. Good afternoon. Firstly, I would like to thanks to the organizing committee to give me opportunity to share our experience and also I think slightly theory for the managed patient with COVID-19, and my topic is early identification and intervention of critically COVID-19 patient. Early identification of critically ill COVID-19 patient can be divided into two which identification of patient infected with COVID and patient who require intensive care. Thanks for Dr. Nobuaki Shime to give us experience from Hiroshima, and I could be discussed after this presentation. First, we will discuss about the identification of COVID-19. Early identification, the gold standard for diagnosing COVID-19 is real-time PCR. But however, since this procedure requires a laboratory with biosafety level at least 2, it is not widely available. Then because of that, clinicians start using thorax CT to evaluate the patient clinical condition. CT scan in COVID mainly showed bilateral GGO, as Dr. Nobuaki said that this is a characteristic for the COVID-19 CT scan. But again, this sign is not specific to COVID only. Now, COVID test has been started to be used widely. We see a rapid test. This test is sensitivity around 90%. Yeah, 88.66%. And it detects both IgM and IgG, and IgM can be detected 3 till 5 days since the onset of symptom. Meanwhile, IgGE can be detected at around 5 days, and it's increased by 4-fold during recovery. 40% of patients asymptomatic 5 days since infection, and 97% patient asymptomatic 11.5 days since infections. Therefore, to use the rapid test optimally, it should be performed 3 till 5 days since the onset of symptom, or at least 8 days since the patient has any contact with COVID-19 infection source. Another new method has been introduced for early detection, early warning score. As we know, early warning score is scoring about CT scan, confirm contact, fever, maximum temperature, ache, and etc. And we can conclude if the scoring more than 10, that is the indicate this patient have to advance to PCR examination. Thus, considering the limited number of RT-PCR facilities in Indonesia, COVID-19 early warning score can be used as an indicator to isolate patients, contact surveillance, and prioritizing RT-PCR examination. And now we will discuss about the patient that require intensive care. This is the second topic that's important. We know that 80% of patients with the mild symptom, but so there are 5% of patients require intensive care unit treatment, and from this 49% need mechanical ventilations. In many cases, for example, in Indonesia, I don't know, in Japan, Indonesia there are limited ICU resources. It means that we have to avoid being overcrowded with patients. Since our ICU bed or mechanical ventilators, it's very limited. Therefore, we have to initiate early detection to optimize treatment in order to shorten duration of hospitalization or intensive care. That's way we can take more patient in. This slide show, as usual, we assess the patient with respiratory rate, heart rate, and oxygen saturation at least 2 times a day. However, in high-risk patient, we must do continuous monitoring. High-risk patients included older age, more than 65 years old, lymphopenia or decreasing trend, patient who need oxygen therapy, or patient with extensive pulmonary infiltrate require continuous monitoring. Now, if the patient are worsening, showing at least saturation is less than 98% with room air, or respiratory rate more than 30, and heart rate more than 120, or sign of organ failure, the patient need to be immediately transferred to intensive care unit. And the treatment is taken over by intensive care therapy, doctor therapy. This is early identification of COVID-19 and management of COVID-19. There are several measures to prevent the disease from worsening. These measures aim to optimize the patient outcome. First, we use high flow nasal cannula, and then the second is restriction of fluid resuscitation, especially in patients with pulmonary edema, and the third is to put conscious patient in a prone or awake prone position. This is the high flow nasal cannula is recommended. This is so treatment earlier for critically ill. One is non-invasive ventilation or high flow nasal cannula and fluid resuscitation restriction and prone position in conscious patient. But if the patient is not improve or getting worse, invasive mechanical ventilation is the optional advance, which is as Dr. Nobuaki said, that ARD is setting, low tidal volume, low inspiratory pressure. Again, prone position is one of the optional. Conservative fluid strategy, high PEEP, and ECMO. But in Indonesia, especially in Makassar, we don't have ECMO, Dr. Nobuaki. All right. Principle of oxygen therapy with patient in COVID-19. Earlier, we give non-rebreathing mask with 50 liters per minute or high flow nasal cannula. We start with 60 liters per minute on FI2 100%. And with this treatment, health worker must use a respirator. Masker must use a respirator mask, N95, and because of risk of aerosolization and risk of transmission of this, and also ROX index, one of the point when we give principle, we give oxygen therapy, that's ROX more than 4.88 indicated that the patient does not need invasive ventilation. Meanwhile, ROX less than 3.85 indicated that the patient is high risk for need for intubation. Same with the presentation of Dr. Nobuaki. I think type of the lung patient with COVID-19. After onset of respiratory distress from COVID, patient initially retain relatively good compliance despite a very poor oxygenation. Many patients do not appear overly dyspneic. This patient can be assigned in a simplified model to type ill, characterized by low lung elastance, high compliance, lower lung weight as estimated by CT scan, and low response to PEEP. For many patients, the disease may stabilize as they stay without deterioration, while others, either because of disease severity and host response or suboptimal management. You see this picture? Yeah. And what about the non-invasive ventilation? Non-invasive ventilation with the mild or moderate COVID-19, it's recommended. And when health worker must use a mask respirator because of the potency or risk of aerosolization, and recommended that do not use an IV in patient with shock or unconscious patient. And administer or non-invasive ventilation for 1 hour, then evaluate if whether the patient improve or reach the safe ventilation criteria, and continue ventilation and re-evaluate 2 hours later. Yeah. So what about the aerosolization? In COVID-19, we prevent to use devices that could give risk of aerosolization. And as we know that non-invasive ventilation and high flow nasal cannuls is a more risk aerosolization than invasive mechanical ventilation. And the advice of treatment patient with COVID-19 in negative pressure room. But the problem is it's not all hospital have a negative pressure room. That's why we also treat the patient in room with normal pressure, but the patient is isolated from other patient with a complete standardized PPE. And to reduce aerosolization when using high FNC, high flow nasal cannula, we put surgical mask on the patient and titrate high flow nasal cannula flow rate from 30 liters per minute. Now, if there's still no clinical improvement, evaluate the patient from clinical assessment and also oxygenation assessment. And it's recommended to do early intubation and mechanical ventilation. And if the hospital does not have high flow nasal cannula and non-invasive ventilation, oxygen therapy, it recommended to intubate it early. But in our hospital, we do first high flow nasal cannula and in non-invasive ventilation. Okay, this is the diagram for suspected confirmed COVID-19 patient with hypoxemia, who evaluate is the condition progressively worsening. If yes, if the patient compos mentis or able to communicate, what about the respiratory rate or saturation? If more than 90%, we start with high flow nasal cannula and then evaluate it after 1 hour. What about the level of consciousness, respiratory rate, saturation? If increased saturation, if decreased saturation and increased respiratory muscle workload or heart rate more than 120, we prepare for early intubation and then patient with mechanical ventilation. The data on mechanical ventilation of COVID-19 patient is difficult to interpret, but several things are clear. Those who require ventilation may require it for long time, and the longer of dependency, the higher the mortality and adverse outcome. It is a very, very high mortality when the patient in mechanical ventilation. Until more universal criteria are adopted for choosing to ventilate, until we continue to use the same mode of ventilation and reported methods, the role of mechanical ventilation for COVID-19 patient is will remain unclear, as presented by Dr. Nubuaki Shime. In our hospital, Unhas Hospital and Wahidin Sudiroso Hospital, we see in this slide all of intubated patients. There are 13 patients, only one survived. It is mortality, it is so high. When high flow nasal cannula, totally 13 patients survive, 10 patients survive. Okay, the last of my presentation, I think, is mortality with use invasive ventilation is COVID-19 is remain high. We can see the red line represent the expected increase in mortality associated with COVID-19, SA, and black line we see represent the idealized ability to reduce mortality to the same low rate for all, irrespectively. And the blue line represent the likely differential impact of invasive mechanical ventilation with more benefit for those who are younger and healthier at the baseline, and less benefit for those who are older and with more underlying health issue. Thank you very much for your kind attention. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof. Assalamualaikum warahmatullahi wabarakatuh. So I would like to thank you again for all of the speakers for the very stimulating presentations. And so we have collected all of the questions from all of the participants in the comment sections, and we would like to deliver it to the speakers. And so the first interesting question comes from Ulfa Sensei, Dr. Ulfa ophthalmologist. He is also an alumni from Hiroshima University. Assalamualaikum, Doc. And he would like to ask to Okimoto Sensei. Okimoto Sensei. So the first question, Okimoto Sensei, do you still in this? So the first question is to Okimoto Sensei. The first question is do the government or hospital, particularly in Hiroshima, do the rapid test or they do the PCR for screening? And the second question is, do the government or hospital do screening only for person in the cluster, or they do randomly testing for other people in a high risk? To Dr. Okimoto.
Yes. In Hiroshima, now,
yes,
we use only PCR tests for screening so far. Now we can use rapid to detect COVID antigen. We plan to use the test as soon. And the second question, we screen patients with symptoms and persons who contact with patients closely. Not all patients.
So you don't do the randomly testing for other people, right, Sensei? So only for the patients who are in the clustering.
Asymptomatic, like breath, like cough, fever, loss of taste. And so we do PCR test. And if the patient has been to outside of Hiroshima, like Osaka, Tokyo, Fukuoka, where there are many COVID patients.
Okay, Sensei. Thank you, Sensei. And
Oh, sorry.
Another question, Sensei, from Dr. Rizalinda. She is also our microbiologist in our university, and she asked about your. She said like your management of clusterings, like testing all of the contact and treatment of the positive PCR and also testing of many people is successfully and quickly stopped the new COVID infections in Hiroshima. However, her question is, how do you protect the other citizens who are not yet immune because no vaccine yet available right now? So how do you protect your other citizens because they are not immune yet?
It's a tough question.
Yeah.
For now, I can suggest citizens to avoid some meats. And if they have some symptoms, please visit us soon. I'm sorry, I don't have a good idea. I'm sorry.
Never mind, Sensei. And also, Sensei, from Dr. Rizalinda as well, she said like in Hasanuddin University or in Wahidin Sudarsono, we also did the same way as yours. Like we did like a PCR tracing, something like that, and clustering. However, maybe because the overpopulations of our society, so the rate of the COVID is still increased. So would you like to share your talk about this, or do you want to add some suggestions about these problems? Thank you, Sensei. Oh, Sensei? Yeah, to Dr. To Akimoto Sensei, yeah, still to you, Sensei.
The question means
I mean, we did the same way. We did also the tracing. We did also the PCR. But we have a problem with the overpopulation of our society. So we cannot like easily to decrease the rate of this COVID. So do you have any talk, or would you like to share your talk, or do you want to add some comments about this, Sensei? About the overpopulation of the society, which will be like increase the COVID.
I'm sorry, I don't have a good idea. Well, Dr. Takafuta, my boss, will answer the question.
So we would give the paragraph to Sensei.
Hello?
Thank you, Sensei. Sorry for taking your time.
May I answer to your question? I believe that your question is that you have too many populations for COVID-19
Yes,
test, right?
So, yeah,
so it's hard to do PCR test for everybody. Is that correct?
Yes.
You have the problem that you have too many populations to perform the PCR test. Is that correct?
PCR and testing, yes, Sensei. Yeah, it's correct.
So actually, even in Japan, we have a same problem that if we have clusters at once, let's say 2 or 3 clusters happen at once, we have the same problem like you. So actually, at this moment, we have a ability to perform the PCR test in Hiroshima, maybe let's say 270 tests for a day at this point. But we plan to increase the test numbers as soon as possible. We plan to increase the numbers for tests up to 2,000 per day in Hiroshima Prefecture. So that's the only way to go through this problem, I think.
Okay,
I'm sorry, I can say just like that.
Okay, Sensei, never mind. Thank you, Sensei. And another question, Sensei, from Dr. Ahyar Latif, ophthalmologist. He's also an alumni from Hiroshima University, and he asked about how about the primer that you use for the PCR? Do you purchase it or you made it? And how about the PCR you perform? Is it a quantitative or qualitative PCR? And yeah, how many times that you run the PCR for the suspected people?
You mean first question should be the primers?
Yeah,
about
yeah,
the primers.
The primers. Do you purchase it?
We perform the PCR using the same primers all in Japan. I mean, every laboratories use the same primers in Japan, I believe. So we purchase the primers, not make by ourselves. And what is the second question? Qualitative or quantitative,
Qualitative
right?
or quantitative, yes.
Yeah. In the central laboratory of our prefecture, we perform the quantitative assay using real-time PCR. We can estimate the copy numbers by the real-time PCR. Right? But in case we perform LAMP test, it's a rapid test of using PCR system. In that system, we can just do the qualitative assays. We cannot estimate the copy numbers using the LAMP test. Is that okay?
Okay, Sensei. And yeah, Sensei, I think it's that explanations cover all of the questions, Sensei. Thank you, Sensei.
Thank you.
Yeah, thank you, Sensei. Sorry for taking your time, Sensei. Thank you.
Thank you very much.
And the next questions is to the next comments goes to Professor Osge from Dr. Risalinda. Professor Osge from Dr. Risalinda. He have a comment about the UV sterilizations that the professor have explained before. So she agreed that the UV sterilizations may kill viruses in the surface of the room. However, it still cannot reach the hidden areas that are not reached by the UV light beam. So here in Makassar, they edit the UV light with the surface cleaning by chlorine 1.0% to increase the decontamination process. So what do you think about this, Sensei? Do you have any talk about this? Thank you, Sensei.
It's for me?
Yeah, Sensei, it's for you.
Okay. I would say ultraviolet is not perfect. You're right. Hidden area cannot be disinfected. So we use this machine to position in the room. So we try to avoid not covered area, but it is not perfect. So we try to use it for reduction of viral load in the environment surface. But as you know, it is not 100% reduction. Is it okay?
Okay, Sensei. Okay, Sensei. I think it's enough, Sensei, for explanations. Thank you, Sensei.
Yep.
And another question is to Professor Mansur Arif. There's a question, and Professor Budu. There is a question from Mudiawati Kamaruddin and Angel from Rumah Sakit Inko Hospital, and they are asking about the sample in the sample for the COVID patients in the South Sulawesi, do you use the DNA sequencing for testing the samples or only PCR? Because she said like the sample or the results is not yet available in GSAID, Prof. And to Professor Mansur, there is a question from Angel from the Rumah Sakit Inko. She is asking about the PCR checkup to all of the staff after they do the shift. So do they did the checkup after they shift or the day after their shift? Like, I mean, tomorrow after their shift. And if there is a positive result in their team, how about the patients? How about the team with the negative PCR? Do they have to be quarantined, all of them, or only for the positive team? So maybe first to Professor Budu to answer the question, and after that, Professor Mas.
Yeah, thank you. As I mentioned before, that like in Hiroshima as well, that for many peoples, in the epicentrum area, we cannot make it PCR directly, and we don't have many reagents.
Yeah, Prof. So
So we just only use rapid tests. Yeah, we just only use rapid tests, and then when we find like a reactive product from the rapid test, the ones we collect, and then we bring to the hotel preparing for next PCR test. That is the answer and the question, Dia.
Okay, Doc. Thank you, Doc. Thank you, Doc. Thank you, Prof. Thank you,
yeah,
Prof.
And then the second one is what's the question, Dia? The second question.
From Angel from Rumah Sakit Inko, Prof. She asking about the PCR checkup from all of the staff in the hospital. I
take from one example for example, from one department, from ophthalmology department. When one of the residential training have a positive for COVID-19, they directly bring the sample swab to test PCR swab. But the others who have contact with him or with her, all of them have to join PCR's testing as well in the others day. Yeah, not only the friends around him or her in hospital, but also all of the family members or who have contact to the resident who have COVID-19 positive. All of them have to be tested by PCR testing. Because the doctor who always do every day be in hospital, so the sample sometimes have to make it earlier and make it fastly to get the results. Okay, thank you, dear.
Thank you, Prof. And how about the patient, the team that has got the negative PCR sensor? Do they all of them have to be quarantined, or only for the patient who got the positive PCR?
Yeah, the negative is the negatives. The team who have joined the PCR testing and then negative, it is we can say this is safe. Safe, no need to quarantine a guy again. when we test it with PCR, but rapid test no. Just only PCR, because PCR testing so that no viral inside in the body.
Okay, Prof. Thank you. Okay, Prof. Thank you, Prof. And how about the Professor Mansur? Do you have the same opinion or the same answer to this, Prof?
Okay, thank you. Regarding the sequencing, we do not perform sequencing until now in our hospitals because of our equipments, and our main business actually not for research. So we follow the rule from Minister of Health, because hospital Wahidin Federal Hospitals belong to Minister of Health. So for positive patients, we have proficiency testing that 10% of negative RT-PCR we send to lead bankers, and 20% of positive samples we also send. So when they test there and there is the discrepancy between our results, and then they will continue for performing the sequencing. So we don't perform sequencing in our hospital. And regarding the if one team, one person positive RT-PCR and another negative, we follow up using antibody detection, not using rapid diagnostic like just minus and negative, but we using antibody detection using cutoff index, and we follow patient every 3 days to 5 days. We measure the IgG and IgM using cutoff index. So you can imagine that not just minus or positive or negative, but we have the positivity, the level of positivity of that antibody from that patient, because we in cutoff index means the signal of the antibody divided by the cutoff antibody. So we know when cutoff index is high, means the higher antibody developed from that patient, and this more sensitive compared just rapid diagnostic test. So this facility we have in our hospitals. So no need more quarantine for 2 weeks if we follow by immunology examination. And our policy again, after 2 weeks quarantine, before return back work in the world, we once again ask them, all health workers, to perform a medical checkup to know the basic condition before work again in the hospitals.
Thank you, Prof, for the explanation, Prof. So next is a question from Professor Shafri. We'll directly asking to the Professor Shime, Sensei. So to Professor Shafri, please.
Thank you, Dr. Dia. Okay, I have one question to Professor Shime. About the using of ECMO, extracorporeal membrane oxygenators. From your experience, Professor Simmer, so what about the outcome of patient with ECMO? We have no ECMO in our hospital, and we do, but we do a cardiopulmonary bypass. I think ECMO similarly with machine for cardiopulmonary bypass. And my question is, how about the outcome? Because of patient with worsening oxygenation, according from all of the reported from all over the world, it's the very bad outcome. Yes. My question is, how about the outcome patient with undergoing with ECMO?
Okay, thank you for the question. Are you asking the outcome for all COVID-19 patients, or the outcome of all patients underwent ECMO service.
Okay, underwent only ECMO, Professor
Okay.
Sim. Yeah.
Okay. So far, we have been applying the veno-venous ECMO service.
Yeah.
That means draining venous blood from atrium and returning the blood to the superior vena cava, which is so-called BB ECMO and also respiratory ECMO. For patients with ARDS and also patients with interstitial pneumonia patients. So far in our institute, the survival of patients who underwent ECMO for such kind of indication reaches 75% or something. Actually, which is almost identical to the mortality outcome in this COVID-19 series in our country, whole country. So that means COVID-19 patient is, I think, a good indication for VV ECMO service unless it is not contraindicated. Thank you.
Okay, thank you for your answer.
Thank you, Prof.
Terima kasih, Dr. Dia. Yeah.
So maybe because we have a limited time, Prof. Sensei. So this is the last question from the Jamal Lompa to Jamal Lompa, to Dr. Jamal Lompa. Do you
Prof.
want
Jamal
to?
Lompa.
Prof. Sorry, Prof. Prof. Jamal Lompa. Sorry, Prof.
Professor John.
Okay, I will try to make it short.
Sorry, Prof. Sorry, Prof.
That's okay, that's okay. First of all, I enjoy this. I'm learning so much. I'm not a medical doctor, but I think this is about science, and I think I learned so much. But because of the limited time, I will ask only one question to Mafumi Okimoto. I hope you can hear me. Since you are able to manage this, flatten the curve and then go down and really maintain it, I'm wondering if we can turn back the clock to the past. Is there anything you feel you would like to even fix or improve so that you can do it better? If you already done a lot better now, can you give us a kind of prediction in the future because of this technology from 4.0 become 5.0 in the future? What is the future scenario of if there is another pandemic coming to the world? How would you able to even improve your preparedness? My last question still to you is, since you have seen Makassar and Sulawesi and Indonesia case on COVID, we still going up. What best advice for us, especially for Makassar, if the governor is still here? What is the best advice? Maybe 2 or 3 best advice for us to follow. Thank you. Terima kasih, Mbak Dia.
Terima kasih. Sorry, Prof.
That's okay.
Yes, Okimoto Sensei.
Thank you for questions. It is too difficult for me to answer exactly, so my boss will answer instead of me. Sorry.
Sorry. let me answer to the questions. First question should be what we can do if we will go back to 1 or 2 months before, what we can do, right? So we had a problem at that point. I mean, in April, we don't have we didn't have enough beds for COVID-19 at that point. So at that time, we had the problem with the shortage of the beds for isolation. So some patients had to stay at home at the facility, and we can't hospitalize all of them at the first time. So I think that it should be we had to prepare more beds for these patients at that point. If we had more beds, we can take care of them. We could take care of them more easily, I think. Is that okay? So actually, we plan to after that in Hiroshima Prefecture, we prepared many beds more than before for COVID-19 patients. So we are ready for the next wave at this point. So I think thinking about your country, I know that it's hard to control all of the patients at once, but one way to control the patients is, sorting the patient from the light patients, moderate patients, and mild patients, and severe patients. So as some of you talk today, it's good for the mild patients. They can stay at home or at the hotel. It should be better to. It's better than to use the hospitals for such a mild patients. And actually, our hospital wants to concentrate for the moderate to severe patients. So in that way, we can control we can control more patients at once. Sorry, is that okay?
Thank you. Thank you.
Thank you.
Thank you, Sensei. So is there any other questions, maybe from the Japanese side to Professor in Indonesia? Is there any question from the professor from Japan to Professor in Indonesia? Okay. If there is no, so if there is no more questions, so let's just summarize the main point of today's webinar. To sum up, we discussed about the management of COVID-19 in both countries, Japan and Indonesia. Even though that we have different approaches of different management, but we still have the same goal to decrease this rate of this COVID-19. So we hope this discussion will deep accommodate to understand the COVID-19. So that's all for today's meeting. Thank you for all the speakers, and yeah, oisogashi tokoro, arigatou gozaimasu, otsukare deshita, sensei. So I will return it to Dr. Rina. Thank you, Dr. Rina. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you very much, Dr. Dia. Thank you very much, Dr. Dia. I would like to say thank you for all the participants for joining us for this in this webinar this afternoon, since this morning, and also mostly appreciated for our speakers, Professor Budu, Prof. Safri, Prof. Mansur, and also Dr. Mafumi, Sensei Hiroki, and Sensei Shime. Thank you very much for your sharing of knowledge and also experience for us. I'm sure that is very important and it's very useful for us in both countries. Well, I would like thank you for all, and I will see you in the next webinar from Faculty of Medicine Hasanuddin University. Good afternoon all. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you everyone.
Bye
everyone. Thank you.
Prof. Mansur.
Thank you.
Ya, sama-sama, Prabudu. Sama-sama.
Terima kasih, Prof.
Terima kasih.
Arigatou gozaimasu.
Prof. Safri.
Arigato.
Arigato.
Prof. Jamal. Arigato.
Terima kasih, Prof.
You can call me.
Salam, ya.
Oke.
Ada moderator kira kita orang Jepang, Pro Jamal.
Oh, gitu.
Iya, soalnya baru datang itu baru datang dari Hiroshima, Bro. Baru datang dari
Makanya dia sebut
Hiroshima.
lompa karena itu bahasa saya Jamara.
Jamara.
Jamara. Enggak apa-apa, Dokter dia.
Dia, terima kasih dia good moderator.
Ya, izin. Assalamualaikum.
Terima kasih, Prof. Prof. Mansur,
Terima kasih.
Salam. Nah, dan teman-teman dekan, terima kasih yang hadir.
Prof, atas informasinya.
Terima kasih, Dokter Rizmalinda.
Assalamualaikum, Pak Prof Budu.
Salam. Siap.
Assalamualaikum.
Pak Prof Lomba. Prof, iya makasih banyak, Prof. Iya. Pak Zainal.
Prof.
Terima kasih, Prof.
Terima kasih, Prof Ridwan.
Pamit ya, pamit. Terima kasih banyak.
Ya, luar biasa presentasinya, Prof.
Luar biasa.
Terima kasih, Prof.
Sugoi, desu ka?
Arigatou gozaimasu.
Oh iya Bun. Iya Bu. Iya.
Terima kasih teman-teman dari luar daerah juga banyak dari.
Iya Bun.
Prof Anwar, terima kasih, Prof.
Ya, kasih banyak.
Iya, makasih banyak.
Terima kasih, Prof.
Iya, terima kasih banyak, Bun. Iya.
Salam dari Bone, Prof.
Selamat. Ulfa.
Salam. Iya, Prof. Masih swasta, Prof.
Tapi saya tidak terima karena tidak nampak cuma fotonya, Ji. Iya, aduh.
Iya, Prof. Udah tampilkan fotonya, Prof.
Oke, Pro Oslan. Ada Pro Oslan juga.
Iya, Prof. Assalamualaikum warahmatullahi wabarakatuh. Ya, terima kasih banyak undangannya, Prof.
Genki desu ka, Sensei?
Hai, genki desu. Kakak sama desu.
Ada gini.
Kalau bisa ada sertifikatnya, Prof.
Ya, insya Allah Dr. Rina siapkan sertifikat, Prof. Insya Allah.
Iya, insya Allah, Prof.
Iya.
Iya.
Ustaz Ayub, Terima
kasih, Prof.
Dr. Elis juga ada ya. Prof Lita, terima kasih, Prof.
Ada apa?
Dari UHO juga ada hadir. Teman-teman Stikes juga ada. Pak Ilham Malimuddin, Dodeska.
Terima kasih, Prof.
Semangat. Terima kasih.
Terima kasih banyak.
Anda.
Mas Ayub.
Iya, Prof. Main besok sebentar, Prof. Main, Prof.
Nanti. Aduh. Ya, masih istirahatin saya.
Oh iya, Prof.
Ada Ibu Ida juga tadi saya lihat ada Bu Ida.
Terima kasih, Prof.
Assalamualaikum.
Ada Prof Anda juga, Prof.
Ada langsung. Ada Prof Hamdan.
Ada Prof Anda tadi, Prof.
Oh, tidak kelihatan.
Masih ada ini.
Itu nyahu, itu beliau nyahu, Prof. Prof Anda itu.
Ada ini, masih ada.
Astaga. Tidak kelihatan. Tabe, Prof, tabe.
Terima kasih banyak, Prof. Pamit.
Selamat, Ki.
Selamat, Ki.
Kemarin juga ketemu di acara itu sosialisasi wawancara S3 tuh.
Oh iya.
Saya intip-intip dari
Sekarang lewat Zoom terus.
Ini juga Prof. Sekaligus halal bihalal Prof.
Ida sudah sehat.
Ii,
Bu Ida sudah sehat. Ya.
Amin. Ngirim
Senangnya alhamdulillah.
Sehat-sehat Prof.
Ya,
Suryani.
Prof. Suryani ada sehat, beliau sehat.
Sehat, alhamdulillah.
Alhamdulillah.
Alhamdulillah. Silaturahim Bu Prof.
Ya, Prof Lomba. Terima kasih sudah join dengan kedokteran UNHAS. FKIK UIN Aludin ada tahu?
Nah, iya, ada juga Ibu Iwi Kausamasari.
Ya.
Oke, terima kasih
semuanya.
Iya, terima kasih Prof. Ya, terima kasih
Terima kasih Prof. Terima kasih Prof. Suryani.
Waalaikumsalam.
Assalamualaikum.
Assalamualaikum.
Salam.
Ada dua dokter Ulfa di sini, ada Ulfa Mata, ada Ulfa Bone.
Iya, hadir Prof.
Iya. Nanda Nihongo Sisumon Nakatana.
Si semua ego desta sensei.
Hiroshima Daigaku alumni karena susra.
Hai.
Kanarasu Nihongo.
Hai.
Dari Maskara. Iya. Selamat ke semua. Oh, selesai. Sugoi, sensei, sugoi. Hai, domo. Wah, selesai.
Video.
Wah, dekannya Pak Betul, dokteran gigi tidak kelihatan gitu kecil-kecil. Tapi kentara Pak, karena ruangannya besar baru rapi itu pasti ruangannya kedokteran gigi. Ada juga di depan kegiatan jadi terpaksa.
Ada juga di Pak Dek.
Assalamualaikum Bu Dekan. Kasih pantun dulu.
Pantun Jepang ya Prof ya?
Saya tidak sempat tadi ikut karena ini ada lagi satu Zoom, ada banyak sekali Zoom ini.
Ini saya paralel tadi Prof, paralel sih. Ada beberapa menguji.
Tongan, ada sibuk.
Alhamdulillah. Yang penting sukses ke semua.
Sukses semua, Bro.
Ikuti juga di presentasi tak, Prof? Ikuti presentasi tak tadi. Mantap.
Alhamdulillah.
Sip, kita sholat dulu. Sukses.
Salam dulu nih. Salam dulu.
Halo, Pak De Gigi. Pak De Gigi.
Sensei, Dr. Ruslen.
Oh, saya 81. Oke.
Ya, selamat. Kasih banyak, Prof. Udah.
Oh, di situ ada pencetnya.
Pak Dekan Andalan, Dr. Gigi. Selamat. Kemarin itu saya live sebelum selesai halal bil halal kayak deh. Datang semua komandan kasih tuh ya. Saya sore-sore ada kegiatan.
Orang semangat Prof Di, tidak ada tersisa waktu.
Betul, semangat semua.
Sampai overlap waktunya.
Bagus.
Selamat ke saya. Selamat ke. Assalamualaikum Pak Dekan.
Ya, selamat. Terima kasih. Makasih kalian semua. Ya, saya live dulu. Ya, terima kasih.
Makasih Prof, izin live juga Prof.
Dete Suhera.
Arigato Sensei.
Tomo. Prof Oslan. Ada juga jauh-jauh ini Bu Lia, jauh-jauh ada dia ini. Bu Lita, Prof Lita, domo.
Ya, domo.
Hai, Mas.
Hai. Shikanai shimasu.
Onegaishimasu, Prof. Iqbal Sensei, Resku.
Hai.
Saya izin live dulu. Alhamdulillah. Terima kasih banyak semua.
Terima kasih banyak, Prof.